Okay, so I did my grand round on a patient who had an MD diagnosis of a left rotator cuff strain after a work-related accident. So the purpose of my grand round was to give an overview of patient findings and the treatment of a patient with the MD diagnosis of a left rotator cuff strain, and to highlight the importance of treating the patient without only focusing on the MD diagnosis and the importance of a thorough PT evaluation. So just a general outline of my presentation. I'm going to start by talking about patient history and the clinical findings and how I use them to develop my interventions, and then the patient outcomes. So my patient was a 29-year-old male, and he was injured at work on October 12, 2016. He was reaching for a ladder that was falling off of the utility truck at work, and when he grabbed the ladder, he had a traction injury to his upper extremity. He noted that he felt a pop and pain automatically. He was sent to the occupational health MD, and they did not complete any imaging at the time, and they just prescribed 8 visits of physical therapy. So then he started physical therapy on November 3rd, and at that time he saw my CI, because I wasn't at the clinic yet. And his DASH score at that time was a 70.5%, so it was pretty high disability. And he had a lot of pain in the left shoulder and decreased range of motion. And they started with mainly low-level activities, table slides, just trying to get the range of motion, get the shoulder moving. And until his authorization ran out on November 30th, by that time they were kind of at moderate level activities. And he had asked for more authorization, but we didn't receive any more authorization until February 6th, 2017. So he had a little 2-month down period of no treatment at all. When he came back on February 6th, that was whenever I completed his initial evaluation. At that point, his DASH score was a 41%, so it had improved, but it was still kind of moderate disability. His pain was a 0 out of 10 at the best and a 7 out of 10 at the worst. It was a 0 at rest. He had no pain at rest. His pain was increased with throwing, reaching overhead, and crawling. He had to be able to crawl for work because he worked for Spectrum TV cabling. So he had to be able to crawl under houses and pull cable. He was having a lot of pain with that. His pain, he described his pain as a snake bite. It was sharp, and he could feel it over the anterior aspect of the shoulder near the bicipital groove. And his pain, his pain would come on with the activities, but it would go away very quickly. He also said that he had clicking and popping with abduction and internal rotation. So for my objective findings, his left shoulder range of motion was decreased. He had full flexion. He had pain at the end range, but he had full flexion. Abduction was 130 degrees, external rotation was 30 degrees, and internal rotation was 1. For Apley's functional reach, external rotation abduction combined with the left upper extremity was at C1, C2, and internal rotation adduction was at T7 for both left and right. Scapular dyskinesis was observed during movement screening, and I observed this movement in forward flexion in the scapular plane. And he also had tenderness to palpation over the bicipital groove as well as the pectoralis musculature. So whenever I performed my special test, I started with rotator cuff test because that's what my diagnosis was. I started with drop arm, did lift off and empty can, and they were all negative. So from there, I kind of had to stop for a minute and decide where I wanted to go next. And with his pain presentation and the reports of clicking and popping with certain movements and not having a lot of pain at rest, I decided to check the labral. So I did the biceps load test, and it was positive, and I followed that with Speed's anterior apprehension and the active compression test. So that's when I started thinking more about the labrum. I still didn't completely rule it in, just based on not really knowing what was going on and still having that diagnosis of the rotator cuff. For joint mobility, I did an anterior to posterior glide and an inferior glide, and they were both normal joint mobility. He just had increased pain. His primary functional loss was being unable to crawl, and this was mainly he could get into the position, but he couldn't maintain the position. He wasn't able to perform the concentric phase of like a push-up, and his vascular and neurological systems were intact. So when evaluating my examination findings, I organized it in the HIAPEP model, with the health condition being left rotator cuff strain or possible labral tear. Impairments decreased left shoulder abduction and external rotation, pain in the left shoulder, decreased left shoulder strength, and decreased strength of the scapular stabilizers. Activities he was having difficulty with push-up, crawling, and throwing. Participation, performing work duties, participation in recreational activities and yard work as well. And then his environment was at home and work, and under houses was kind of at work because he had to be in a lot of weird environments at work. And then personal factors, he was 29 years old, he was a male, and he was very motivated. So when thinking about my medical diagnosis and the special tests that I performed, I started thinking more about the labral or the labrum, and I started to think about this because of the pain presentation. Without most labral tears have been found to be painful with movement, with little pain at rest. And then a common mechanism of action for injuries to the glenoid labrum is a forceful traction injury to the upper extremity, which he had. My primary PT impairment, I decided on decreased strength of the shoulder and scapular stabilizers. And I decided on that because he was able to obtain the positions that he was having difficulty with, but he was unable to maintain them without increased pain and compensations from other muscle groups. So I started focusing more on what problems you could have if you had a deficit to the glenoid labrum, and looking at how that can cause shoulder instability through my research. And so just a little review, the glenoid labrum enhances shoulder stability in 4 ways. It limits humeral head translation. It increases the concavity compression between the glenoid and the humeral head. It increases the stabilizing effect of the long head of the biceps anchor, and it increases the overall depth of the glenoid fossa. Okay, so for my plan of care, I was originally authorized 8 more visits. So to get the most out of my 8 visits, I did 2 times a week for 4 weeks. And he was very motivated, and he was extremely compliant with his home exercise program. We had a whole TheraBand station at home, and he did his exercises 2 to 3 times a day on his own. So I knew that he would do what we needed him to outside of therapy as well. And just a little background too with the plan of care. My CI saw him for 8 visits, and then he came back and I had him for 8 visits. And then there was another 2-week down period before we got reauthorization again for another 8 visits. And in between there, they finally did an MRI. And then we had him for the last 8 visits up until he finally got to see an orthopedic surgeon. So my goals for PT were focused on returning to work. So being able to crawl and lift, and then just overall his dashboard decreasing. So for his treatment, I found research that for non-surgical healing of the labrum, that exercises that had worked were stretching, strengthening, and really focusing on increasing the stability of the scapula and the glenohumeral joint. So I started each treatment just with a warm-up on the UBE, just to get things moving, blood flowing, and then I would do some manual therapy. And joint mobilizations were mainly grade 1 and 2 because his mobility was fine, or like in the joint, it was more for the pain. So we did anterior to posterior and inferior mobilizations. Also did soft tissue mobilization of the pectoralis musculature to decrease the pain. Passive range of motion into abduction and external rotation to try to gain some motion there. And then I did manual PNF and manual perturbations to increase stability. So for the manual PNF, I started by just guiding him through the motion, through his pain-free ranges, and worked to him doing the motion properly on his own, and then started applying resistance. And by the end of our entire treatment, he was able to tolerate moderate resistance through a PNF pattern. And then for manual perturbations, I changed his positions. They were always in supine, but I changed the position of the joint when doing the perturbations. And then for the first 16 visits, my CI performed dry needling on the pectoralis muscles for pain, to decrease the pain. And then he stopped doing that after the first 2 rounds of PT because his pain in the pecs decreased. So for strengthening, I did periscapular musculature and shoulder muscular strengthening. And then for a work simulated task and functional activity, I did a progression to crawling. So just some examples of some of my treatments, and then the background behind why I chose them. I started with my research looking into enhancing the stability of the shoulder. So strengthening the rotator cuff was an automatic go-to, as well as the serratus anterior and the lower traps, getting them to fire in the proper sequences. Because through my research, I learned a lot about once the injury occurs to the labrum or any of the shoulder muscles, that everything can start firing in the wrong sequence. So I wanted to make sure I was promoting proper force couples and getting everything to fire in the right sequences so that I didn't develop any other compensations that could negatively affect my patient. So I started a lot of when I started with my patient, he was already at that moderate level. They had already progressed past doing things on the table, but sometimes I would revert back to going and positioning him in supine or prone, just so that I had the opportunity to make sure I was seeing him activate everything properly. And then we moved to the wall and do serratus slides with the foam roll or resistance. We did a lot of wall ball for stability, changing the size of the ball and the weight of the ball. Lower trap activation with Y's, sliding up the wall with lift off, and then changing to unstable surface. And a big focus was really just watching him and even giving him some guidance to make sure that he was using the proper muscles and not compensating. And this is just a few more examples of treatments that I used. So I started with internal external rotation with 0 degrees of abduction. I worked all the way up to 90. But then after doing more research, I actually discovered that 45 degrees was a more optimal position, not only because it put less stress on the labrum, but it also, I found that it targeted the activation of the rotator cuff more highly than at 90 degrees. And through my treatments, I also found, or I had a reminder that strengthening the core is important to get stability of the extremities. And you'll see that with my functional progression to crawling. So to start crawling, we started with just a basic push-up on the wall, standing up right and making sure he didn't have pain with this motion before we moved on. And we didn't stay here very long. He was able to do this. He wasn't having a lot of pain, and everything was going well. So we moved to an inclined push-up off the table, and we did eccentrics. So he would go down, and then he would walk back towards the table to come back up. And after he was doing okay with that, we moved on to doing a full incline push-up. And from there, we went to the ground into a modified plank position. And from there, I tried to go straight into doing a plank after he was strong, and I noticed that he wasn't compensating any, but that was too hard. So we reverted back to a modified plank position with alternating upper extremities. And then we went to a plank, and then a full plank with alternating upper extremities, getting more of that crawling motion. And then he told us that at work, while he's under houses, he's having to go up and over things as well while he's crawling. So our final thing and where we were at when we ended was doing high to low planks. So for modification of treatment, I based it on my patient's response and mainly his pain. So if he came in with increased pain or he was compensating with any of the exercises or functional activities, my example was the plank, reverting back, going back to a modified plank, but changing it another way that it was still challenging to him, but it wasn't increasing his pain to where he wasn't able to do as many. I also I didn't have to modify, but it made me more confident in my treatments whenever he had seen even though the occupational health MD was the first one to say that his MRI came back with a positive for a labral tear, and they were still waiting for confirmation from the orthopedic surgeon, it made me feel more confident that I was doing the right things to help him to develop the stability and the strength before he went into surgery to repair the leg. So his response to treatment, his quick dash remained a 41% throughout my whole treatment with him, because he was still having that pain with the higher level activities. So when it asked if he was able to do his full job, he wasn't. So all those things were staying the same. But it was a clinically significant change compared to where he was at when he first began physical therapy. His abduction increased from 130 degrees to 155 degrees, and his external rotation was within normal limits, so I didn't note it here, and I just talked about the functional reach. And the external rotation and abduction increased from being at the C1, C2 level to T1 of the left upper extremity. And for his strength, flexion was 5 out of 5, external rotation was 5 out of 5, and internal rotation was the only one that was a 4 out of 5, and that was more because he had a lot of pain whenever you resisted it. But then with abduction is 5 out of 5 within his available range. So it's not a true 5, but he had a lot more strength, and he just wasn't getting through that range because of pain. So for his home exercise program, I know you're not supposed to give as many exercises, but because he was so motivated and he wanted to do so much at home, I justified giving him more. And I wanted him to have a carryover, since when I saw him last in April, I knew that he wasn't having surgery until, he didn't know, sometime in May. So I wanted to make sure that he still had a lot of the exercises we were doing in the clinic, and that he was doing the ones at home, that he was doing the best in the clinic. So I wanted to make sure he wasn't doing any of them at home on his own that he had compensations with and needed tactile cues with. But I wanted him to be able to maintain the strength and stability we gained throughout the PT sessions. So he was doing the straightest wall slides, TheraBand wall walk, straightest anterior punch, resisted D2 DNF, external rotation with 45 degrees of abduction, and he was stretching his pecs with the doorway stretch at home. My biggest limitation was that it was workman's comp, because it was really hard to get authorization. It was over a 6-month period. He had 24 visits. And after the first round of PT, he had a 2-month downtime. In between the second and third, he had 2 weeks. So there was a lot of downtime where he was getting no treatment, and it took a long time to get imaging. It could have expedited the process and got him to surgery a lot faster than it did. And that was just, there were things I probably could have done different. I probably could have called more and been on or tried to get in touch with his case manager more. But it also depends on their case manager and how motivated they are to keep the connections going as well. So in summary, after treatment, the patient had improved range of motion, strength, and stability of the shoulder and periscapular musculature. However, he still had increased pain with work and recreational activities. He was able to do more, like you saw, he was able to do the high-low plank and recreational activities. He was able to go to the gym now and play basketball with his friends, but he still would have pain afterwards. And he's going to be having surgery sometime in May to repair the glenoid labrum. And throughout the process, I learned a lot about the importance of tactile cueing and making sure the muscles were firing in the right sequence, and as well as focusing on the core to get the stability of the extremities. And it was also a learning experience for me and I chose this patient because of the level of activity he was at whenever he came back to therapy, because I do really well with lower level patients. And this was a struggle for me to have to come up with other exercises and really focus on the muscles and what they're supposed to be doing. And just getting everything working correctly. So it was really helpful to have my CI there and helping me catch form and things that I should have been paying more attention to sometimes. Questions?
I was just wondering, what is, for the labrum, what is speeds?
For speeds, going up.
Okay.
Speed test.
Help
We did that. We did do a speed test.
I don't know if we did. I learned it in my first orthopedic rotation. I don't remember.
We cut some out. Stress and biceps, and because of that attachment to the labrum, you can sometimes get a positive for that labral tear because it is. Do you think so? Tell me. Do you think you needed the MRI? Do you think he needed the MRI?
I don't, but with workman's comp, they would not approve a surgery without, or like they would not approve any further treatment, and he wasn't getting that last little bit of progression that he needed.
Do you think that his outlook changed after the MRI?
No.
Was there like a change in his ability to progress? Do you think it impacted him at all?
No, we had already pretty much told him that we were pretty confident that it was a labral injury.
Yeah.
And that we were going to do, like, we explained the labrum, we showed him some anatomy of it and what it was doing, and told him why we were doing the strengthening. And he was still getting better, not with the quick dash, but he was still getting better, like, functionally, and he saw that he was still getting better functionally. So I don't think having the MRI really changed anything for him. I think he was kind of grateful that they finally got to that point, though, because it had been so long. And he's supposed to leave for missionary work soon, and there's just a lot of factors, and he wanted to get back to work and make money, and he couldn't do any of this. And
do you think that because it was a workers' comp situation, do you think that affected his dashing?
I don't, based on the patient.
Good. Yeah, because I mean, there are times when you can have a labral tear and get your shoulder stabilizer strong, and not need to go back and have surgery. So, you know, that could have been something to counsel him on. Now, obviously, if he still has pain and he can't do those things, then
yeah, and
say,
it was
okay,
decreasing, and he saw it that it was decreasing. Like he could tell, like, I can do this high to low plank, and it's not increasing my pain as much. He could go and play basketball, and he was doing okay. But they were still just at the end of the day, like, he knew he couldn't crawl completely under a house all day and not have the pain.
Sometimes the challenge is there too. Are you've got other people at work talking to you, and saying, "Hey, if you don't have the surgery now, come back to work. They might not pay for it down the road. Then you're gonna have to pay for it, and those sorts of things."
And
so
that's a big challenge with the occupational health MD as well, because they know that process so well that sometimes they plant that seed in the patient's head.
So great job of not biasing yourself into that rotator cuff pathology, and really use that health condition to help guide your treatment, but not even direct your treatment at the labrum. Look at his impairments and treated what he needed, keeping in mind that